Welcome back to The Exam Room, a podcast where we dive deep into the world of value-based care, patient-centered healthcare, and improving health outcomes with your host, Dr. Rhiannon Winsor. Dr. Winsor is a certified surgical technologist, healthcare educator, and the manager of training at VB Care Network. With almost 30 years of experience in healthcare and instructional design, she's spent her career helping clinicians and care teams optimize patient outcomes. You'll also hear from Bent Brayman, our media and graphics design producer here at the Exam Room podcast. Bent brings over a decade of experience producing multimedia content in the healthcare space, including work with major organizations like the Core Institute and the University of Phoenix. From video production to motion graphics and audio storytelling, he's the creative mind behind how this podcast looks, sounds, and feels. And when he joins the conversation, he brings a unique perspective grounded in both design and real-world healthcare experience. What happens when providers treat every patient like they matter, regardless of their insurance? In this episode of the Exam Room podcast, Dr. Rhiannon Winsor and guest Shaun Romero challenge the deeply embedded fee-for-service mindset and explore how standardized, relationship-driven workflows can change everything. From burnout to trust building to care gap accountability, this episode will leave you rethinking how we show up for patients and each other. Let's get started.
I was having a thought about the FQHCs, and you were talking about how it's more difficult for them to kind of really focus on this value-based care model, especially when they only 10%, let's say, of their patient population is, kind of falling under this model. Is it feasible to look at all of your patients through that lens, or no?
I think that as a clinic, we did it, and I think it is. And I think that it's not only easier for the providers to manage that type of workflow where they treat every patient as if they're, like, say, the same insurance plan. We're looking at quality, we're looking at gaps across the board. Doesn't matter what insurance plan affiliation you have, we're going to treat you like a human. I think it is possible. I think that the challenge is the mindset around that framework. And I've heard others talk about how it's this fee-for-service chassis that we're working off of. And that is just so hard to change, because a lot of providers take it, well, if there's no incentive for me to do X, Y, Z, then I'm not really, I'm in a way, it could word it better, but wasting time when I could be moving on to the next patient. And so that, again, is the fee-for-service chassis that's kind of dictating that mentality. So I think that in the scenario where you've got providers who are looking at value-based care and they're treating everyone the same, the incentives are there. There might be a little more risk, there might be a different incentive structure, but the management of the company needs to kind of fall in line with that in order to push that care. Every patient has gaps in care. Every patient has some opportunity for quality. Just because, I'm your provider, I'm seeing you here today, doesn't mean that there are other elements of your care that are that I should necessarily ignore that happened maybe yesterday or a month ago, or a specialist that you've seen. There are other parts that tie into the full picture of that patient's care. And I think that if we're looking at a approach that adopts all the same workflow for all patients, the same looking at quality for every patient, whether it's there checking gaps, mammograms are important for people, colonoscopies are important. Doing regular screening for certain events that we know people are going to have is important regardless of the plan affiliation. Yeah. And so the challenge, I think, is really making sure that workflow is a sustainable process within the clinic, and making sure that the alignment of that is set based on management, that is the focus.
Yeah. I know I want to be cared for in that way as a patient.
Yeah. I think that it also, and organically, that drives a relationship too, right? If you've got a provider who is consistent on taking the same type of, quality approach with each patient, they're going to get better at that approach. Mm-hmm. Now, if you have a provider who's looking at a patient's chart and says, well, wait a minute, okay, they're with this insurance payer. Okay, well then I don't need to do this, I don't need to do that. But they're in those brackets where, you know what, there are indications that maybe you should look at it, but it's being set aside because the importance doesn't have the same value at that time, is I think harder to manage. So it's better to have a provider have the same workflow across the board, regardless of plan affiliation, because you can manage that compared to a multitude of different workflows. And we found that was hugely successful for us. Regardless of the patient's plan, we treated them all the same. We wanted to really, if we treated everyone like they were in the denominator, we wanted to make sure that we got them in the numerator and we satisfied it. Didn't matter if there was a financial incentive, because in the long run, for providers to have that better engagement and enjoy what they're doing, there needs to be less of the mechanical effort in the background of, well, this person, not that person.
Yes, and the healthcare industry is highly regulated. Lots of policies now associated with that. There didn't used to be, right? And so I can't imagine being a physician today and feeling what all of those barriers feel like, all these barriers between me and my patient, and just being able to give them the care that I know they need without all of these additional barriers.
Yeah. And that what you see is providers step back and say, I'm not doing that. Yeah. I'm not going to take on this plan because it doesn't fit with my workflow that I know I can successfully keep doing, and may be slowly trending off because of the way the industry is going. It's not going to be, in 5 years from now, it's going to be a very different picture of what that type of clinic looks like. But pushing back on workflows and pushing back on plans that actually make sense to deliver care, but it's so different from what the clinic's doing, they just push back and say, I'm not doing it. Yeah, that's unfortunate.
I think that when you're talking about the fee-for-service chassis, I think one of the things that a lot of providers don't necessarily realize is because they've been trained since the 70s to kind of operate in that way, the fall off of treating it almost just completely transactional affects a lot of other things that they don't consider, which is patient retention and also provider reputation. And when you approach patients from a value-based care perspective unilaterally, the benefits are the patients are going to recommend you as a physician. You're going to be more engaged with your patients, and also you become more of a leader in the community, and it becomes a much more elevated population health thing where you're helping people in your community, and they're all benefiting from your care. So that with that fee-for-service thing, because it's almost like going to the Genius Bar at Apple, where you have you have 15 minutes to help me with my iPhone. My iPhone could be completely janky, and that 15 minutes we might not even solve the problem. And I think that we've, as a society, have shifted so far to everything being this very transactional thing instead of having empathy and care in that way. And when it comes to burnout, because of these barriers that these physicians are running into, I imagine that those come hand in hand with compassion fatigue, because it's going to be harder to really be invested in the care when you have this back burner of stress of the bureaucratic aspect of what you have to do. Yeah.
I mean, it's in a lot of clinics, and ours was the same, where provider gets out of the exam room and there's an insurance rep in the hallway. There's not the moment for them to breathe, right? And that's even more stressful. So when you think about providers, they're instrumental in someone's care, and they can be a huge benefit, or if they don't have the right data, they could be a detriment. And that weighs mentally on the provider. So they're definitely they're getting compressed from all sides. And it's not only that it's not that they're not engaged as much, but I think they disengage because they can't engage in a lot of cases. I can't render care the way I want, so I'm just going to do it in a safer way that I know I can comfortably move forward to the next patient. And I think that's what we see a lot of. It's very transactional, like you said. And that's unfortunate because it's an industry that it shouldn't be transactional. And there are a lot of studies that show that the relationship a patient has with the provider really drives their care. That's hugely important. And in a lot of these collaborative models, have shown as well. Like if a clinic is offering more whole body type of approaches, mind and body, and saying, hey, provider, we're going to empower you to be able to actually be way more, instrumental in this patient's care, because you don't have to say, I'm not concerned about this part. You can kind of fold that into your normal care model and be really important to that patient long term. Those models really help patients and providers connect better. But it's when you have the head separated from the body scenarios, whereas I can't do anything with that. Sorry, go self-refer, go find a specialist. That's not what patients ever want to hear.
No.
They're deferring to that authority to kind of give them some solid direction. But if that authority's like, hey, that's not my concern, then that stands out a lot more than what may have been solved during the visit sometimes. That feeling of, I was displaced. Yeah. This isn't what I wanted. So yeah, there's a lot of weight on providers. And there's a lot of opportunity. And that's the thing I think it gets lost a lot of times with these clinics and providers that have a fee-for-service chassis, is that they all have the power and the opportunity to jump in a big way into value-based care, but they're the ones that are holding it back because they're afraid of, how do I do it successfully, and how do I do it so I can also be viable? Yeah.
So burnout. I want to talk a little bit more about that. We talked about automating workflows and those kinds of processes. What are some other things, words of wisdom that you have about reducing clinician burnout?
I think that when it comes to burnout, and the numbers, I think in Arizona, there's like 46% of providers are experiencing burnout in some way. And I've heard other studies that even suicidality of providers has gone up a little bit, and it's kind of scary to think that we're in this environment where it's not getting better, and providers are challenged to the point that they want to quit. I think a lot of the burnout that we see is because of, again, like we mentioned, just being overwhelmed. There's just too much data to try to access during each visit. There's too much to pay attention to, and it becomes this just thinning of what I can do now, and I'm just going to focus on a few things and then kick the can down the road later in a way. I think that contributes to burnout considerably, because providers a lot of times are providers because they want to treat people, they want to help people. And if you're in a position where you're being kind of systematically told, you can't help them here, just help them on what you can, that mentally wears someone down a lot. I think the other challenge that providers have is that there's a lack of team effort sometimes. I think that the support mechanisms for providers are not necessarily there. A lot of times you'll see providers kind of keeping their information for their patients, in a specific way, whether it's a document or something. They feel like they're off on their own. And having a team atmosphere is, I think, hugely important, and to kind of let providers know you are supported. Just like the patient needs to feel supported, the provider needs to feel supported too. And you've got that is a huge challenge that contributes to burnout. I think the other issue is that there's a providers shift around from position to position often because they're not feeling the connection that's needed for them to grow a relationship with patients. There's been a lot of groups that have come into Arizona over the last several years. Providers have shifted from group to group to group to group, and I think that sets up an expectation that grass is greener on the other side, and it really isn't in that sense. It's green over there as well as it is here. And I think that adds to provider burnout because the expectations fall short of what the reality is. They're not experiencing what they need to feel like, okay, this is a good move for me. It's a lot of settling, a lot of compromising, and it's a lot of the same, but just a different environment, different, feeling, different room. When providers focus on patient care, when they focus on the quality of the care they have, that they can administer, when they focus on the team atmosphere and they focus on the relationship, you typically have better results. There was I think a study a couple of years ago from JAMA that talked about the team atmosphere. Daily huddles, You can reduce burnout by like 20% in some cases if providers are just doing this daily engagement with the team. And that I don't see a lot of. And when I do see it, I'm like, this is great. Like, it is a team atmosphere. And, in sports teams, there's a huddle. There's let's communicate. What's our next play going to be? Every day is like another play. And having that communication re-engages the providers to recenter them, so they know they're not alone. They know that if they need help, they can ask for it. So the open line of communication, all of that is important. And I think that's something that's not widely adopted as much as it should be, is the open communication. There's a lot of, well, I know what I'm doing, don't question. It's not necessarily questioning as much as it is knowing there's an open line of communication. So working and building off of each other and learning from common experiences, but being able to have that open line, that channel of communication is hugely important, and I think is very valuable to help offset provider burnout. Now, a lot of the stuff that we see for burnout, I think, are a lot of emergent behaviors and things that come out from the current structure we operate in. And so I think it requires us to also step back and say, you know what, we're creating a lot of this burnout just because we're adding more and more and more and more. And you can see that in many ways. We're not only adding more data, we're adding a multitude of new plans. We're adding new subsets of patients here, new SDOH, new social determinants of health type of material that we want providers to focus on now, and it just becomes more and more and more and more. So I think we're obviously going to have to continue adding more as we develop as a society and we learn more about the analytics of patients' health. But how do we do it without putting more layers and more in front of the provider? And that, I think, is one of the biggest contributors to burnout, is we're layering on too many things.
Yeah.
I think also, speaking to the collaboration part of it, like if you have these team huddles and you're like able to communicate with your staff, like you understand like a lot better what your resources are. And when you understand your resources, that can kind of generate enthusiasm amongst the team. And so like when your team is all rooting for each other and for you, it's so much easier to get through your day and have like that engagement with your patients. Also, to speak to the burnout side of it, is a lot of, I think, physicians are experiencing right now is like there's been a huge reduction in the workforce on how much actual help that they can receive. And when we're talking about things like social determinants of health, if you don't have somebody that really specializes in tackling some of those challenges, you're having to rely on MAs and nurses that don't necessarily have that training. So you're setting this expectation up of like, okay, like not only do we need to care for this patient's particular presentation, but like we don't know if they have adequate transportation. We don't know if they have access to food. There's a lot, especially in these rural areas, that our federally qualified health centers work from. What are some of your recommendations for folks that maybe don't understand what resources they have available, and how do you think that they can work with a reduction in resources? Like, what would you recommend?
Yeah, I mean, those are all very great points. There needs to be almost a champion for each clinic that focuses on those other sets of information. SDOH, when it comes to transportation, patients aren't going to come in if they can't come in, right? So you have to have, I think the systems really speak to how successful you can be. And I think historically, again, there's been a lot of groups who just add on additional systems, additional layers. And you almost need a system that automates the process of the screening to the provider, to the referral process, to the referral loop, and then follow-up. You need a way to look at that and say, you know what, here's what you need, patient. Let me, as a provider, drop a code which will relate to this referral event and have that automatically generated. And then we're going to have a care coordinator talk to you in person, because we need to limit the time that we have humans doing admin work and focus more towards the human work. And I think that is where we have to make a fundamental shift. You have to always have someone who's going to be a champion for the patient for a variety of reasons, but they need to have that personal communication. But again, we're in this world where we now can automate a lot of things. There isn't a reason why someone should be pulling up Excel lists and saying, okay, well, these 10 patients got this code, let's reach out to them. It should be almost embedded within the process. The provider finish the visit, and then you get outreach. Because we know the sooner a patient gets outreach from a clinic from their visit, the more likely they're going to continue with things in that care plan, or the more they're going to remember what the next steps are. If you're getting a call 2 weeks after you saw your provider and like, hey, Mr. Smith or Dr. Smith told me I need to reach out to you. Well, already I've lost the patient, because now it sounds like it's a cookie cutter thing, but it's too disconnected.
Yeah.
The continuity of care needs to be really continuous. And so systems that allow people to pull away from the administrative burden, which means you can add more layers in that automation, but it's not going to be perceived as layers for the staff, additional staff training. And then this is, again, in a perfect world where we don't have turnover and your staff is consistently there and they're working 7 days a week, so like there's a lot of the human element is best served if it's human to human. And it's not really functioning all that well when it's human to computer and back and forth, because we can now do computer to computer. That's where we need to really remove that effort and get it back to the personal connection and shorten the time and the distance, in a sense, that it takes for us to go from visit, diagnosis, connection to the patient, follow-up, and then scheduled follow-up visit,
Yeah, and I'm also thinking that this is perhaps where the ACO can come in and offer some of that support to the health centers regarding SDOH or connecting them with resources that they need. But if we're not engaged with our patients, we're not going to know that they don't have transportation, that they can't afford their medications, that they, so I don't really feel like, in my experience, there's been a lot of times when I felt like the provider was actually taking that time to even figure that out, or to get to know me well enough, or where I would feel comfortable enough or trust them enough to be able to share that, right? Because if it's not that easy for me to sit here and say, I'm really sorry, you want me to take this medication, but I can't afford to get it. I'm probably just not going to say anything, and I'm going to go home and I'm not going to get my medication and I'm not going to take it because that my pride is wounded, and culturally, some of those practices, like those are just things that you don't talk about.
Yeah. I mean, if you're going to really appeal to a multitude of demographics, you're going to have a lot of different challenges that come up, and you're not going to get the same result with every single person. And so how do you administer care to people that may not be telling you that challenge? And I think ACOs can play an instrumental role in providing resources to groups, not only in the form of IT infrastructure, but also regular training and follow-up in relation to those patients and those challenges. So I think one of the things I've seen is that providers sometimes don't understand why they need to do something outside of what they normally are focused on for medical. Like, I'm not going to ask the patient about, do they have high quality food? That doesn't make sense to me. So I think the clinics, if they're going to go into a relationship with an ACO, they also need to have an understanding of the benefit of that. What is the reason why? It's not hopefully to add more to your panel and to open up opportunities for more revenue. That obviously should be part of the scenario, but the ultimate aim should be to become more successful and improve how you administer care. And I think a lot of times that gets lost on clinics. So ACOs have, it's incumbent upon them to make sure that they've got training mechanisms, regular contact with the key people who make decisions in the organization, so they understand, hey, if you're able to do X, Y, Z, you're able to engage patients on this level, you're able to get these outcomes, this is how it's going to translate to you as a clinic. And that's what matters. And your providers are also going to feel that engagement. If you're asking a patient, like in that scenario for medications, if a provider is able to engage with a patient about those challenges that aren't necessarily medical, but are financial or logistically, they're not able to get into the clinic, then that's something that's a different level of relationship that the providers. Now, I know that patient has trouble with their car, so I'm gonna make sure that the staff, that we have a way to call a family member. We make sure that we have a HIPAA consent on file, so we can call someone else we know that can get them in there. The way you approach that patient is going to be a little different, in that you're going to wrap around those issues might get in the way of their care, as opposed to ignore them or not even have a conversation about it. So I think the ACOs can give a level of insight on the workflow that clinics are not using, that they can help implement to get through to the patient, because those are the parts the providers don't have time to even think about a lot of times. Again, they're going from patient to patient to patient. Someone's in the hallway, they're looking at charts during lunch. There isn't a moment for them to think, well, how could I have done that differently? It's just going to be another of the same workflow for the next patient. So giving them those opportunities to learn, but putting it together so they understand, I think is the ACO has a unique position. They can do that.
Yeah, and when I was running my program at Pima, I was responsible for my retention rate of my students, right? So that forced me to get to know my students even more. Like, they're not coming to school. One student, he didn't have gas for his motorcycle. I'm like, all right, that's why he wasn't there. He wasn't coming. I don't have money. I can't get gas for my motorcycle. I said, the next time that you cannot get gas for your motorcycle, you call me. And he did. And I gave him $20 and he came to school. But, holding providers accountable for those care gaps, is that a thing? Is that a bad thing? Like, what might that look like?
Yeah, that's an interesting element to care. I think you can provide incentives for them to close gaps, to focus on quality. And that needs to be the ultimate aim. If you're signing up a provider and their contract says, hey, you're gonna focus on quality. Here are some key metrics we really want you to focus on. Embedding that in the beginning of the employment contract, I think, is important. And you're gonna get providers who understand, okay, well, that's what I want. So hopefully you'll attract providers who are interested in that type of care scenario. But you have to have the incentives aligned properly. If you're a group that's assuming some risks, then you've got to just kind of take that on and not pass it along to providers, because then you'll have more provider turnover. So there can't be a disincentive in a sense.
For sure.
You can't take away from them, but you can add more. Reward them for great behavior. And I think that's with value-based care and with ACOs. For federally qualified health clinics, if you've got providers who are aligned to treat every patient who comes in the door, getting them to also focus on quality and another visit or a follow-up visit is where that challenge for ACOs is going to be, because you've got this training effort. Okay, now here's why you need to advocate for that patient to come in again. And maybe little small changes, like instead of having the patient go to the front desk to schedule a follow-up visit, you schedule it at the end of the exam. Like, take that opportunity, let the patient know, hey, as provider, I'm scheduling with you. I want to see you back in 2 weeks. What works best for you? Gets a different level of engagement than, here's your encounter note, go to the front and schedule a visit. So little tweaks like that make a huge difference, but it starts with the provider getting the knowledge of, well, this is why I'm doing this, is because I want them to follow up. This might have been the first time that we're seeing a patient today, but I've identified they've got 2 chronic conditions, and one of them's uncontrolled. I really want to see them back. So in doing that and keeping their attention is really a training effort, and getting the providers to understand that is part of that effort. So, and that bridges one of the gaps that ACOs are trying to do with quality and reduce cost is having the follow-up, preventative. How do we get in front of these issues in a way that keeps them out of the hospital, that they get the medication when they need it, so they don't have an issue that pushes them into the hospital. So that training effort, I think, is huge, but it really starts at the provider level a lot of times. But they need to have the bandwidth. So this is where the problem gets compounded. They need to have the bandwidth to say, okay, well, yeah, I'm comfortable doing that without feeling the pressure of, okay, I got to get in the next visit. You know, they've got to be able to do that and be successful at it. Yeah.
Thank you for joining us in the exam room, where we examine the vital signs of value-based care and diagnose what's shaping the future of healthcare. We hope this conversation was as insightful as your last checkup. A big thank you to our guests for sharing their expertise and prescribing actionable ideas. Stay tuned for more episodes as we probe the topics that matter most in value-based care. Until next time, take care, and thanks for listening to The Exam Room.